Good evening, everyone. On behalf of Inter Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this 21st episode of Endocrine Talk Show. Over the course of our journey, we have explored various facets of endocrine disorder, from diabetes to adrenal dysfunctions and beyond. Each episode has been testament to our collective effort and commitment to advancing knowledge and patient care. Today, we delve into another interesting topic, thyrotoxicosis demystified. Thyrotoxicosis presents a myriad of challenges in diagnosis, management, and patient care. In this episode, we aim to bring clarity into this intricate condition, shedding lights on its clinical manifestation, diagnostic approach, and therapeutic intervention. And to guide us today, we're having with us our co-director for the program, Dr. Subhankar Chaudhary sir. He is a director at Department of Diabetes and Endocrinology at Medica Super Speciality Hospital, Kolkata, and former head for Department of Endocrinology, SSKM Hospital, Kolkata. We are fortunate to have with us Chaudhary sir and request him to introduce our esteemed panel member and start the proceeding. Over to you, sir.
Thank you very much. A very good evening to all our friends who have joined and are going to join from across this country, and of course to our very special esteemed panelists this evening. We are always very fortunate to have excellent people to help us guide through tricky topics in endocrinology to help our busy physicians in their daily practice. And this has been going on for the last so many months, years actually. It started during the dark days of COVID lockdown, and it has continued because of the interest shown by people across the country. So this evening, we are once again very fortunate to have 4 dynamic endocrinologists from different parts of the country. So we have with us none other than Professor Rakesh Sahai, who is Professor, Department of Endocrinology at Osmania Medical College, Hyderabad, as also the President, Endocrine Society of India, Vice President, South Asian Federation of Endocrine Societies, and he has many other feathers to his cap. And I'm sure he doesn't need introduction to this audience. We have with us also very senior endocrinologist, Dr. P.S. Lamba, who is a consultant endocrinologist at different major hospitals in Bombay, Fortis Hospital, Mulund, Hiranandani Hospital, Vashi, Reliance Hospital, Kopar, Khairane, and he has served for more than 25 years in the Indian Navy as a consultant endocrinologist. We also have with us Dr. Srirang Godbole, who is a very renowned endocrinologist in Pune. He is Associate Professor, Department of Diabetes at Jahangir Apollo Hospital. He's also a consultant endocrinologist at Institute for Treatment and Research in Diabetes and Endocrinology. We also have with us Dr. Ritesh Kumar Agarwal, who is a consultant endocrinologist at AMRI Hospital, Bhubaneswar, and he has his own publications, and his major research interests are diabetes and thyroid disorder. So welcome all of you to this next episode of Endocrine Talk Show. So my first appeal is to all our participants, audience, that you are the focus and you kindly put in your questions, and we shall then put them to the relevant panelists. By the time that you all get ready with your questions, maybe we will try start off with a few openers. So to set the ball rolling, can we have Dr. Lamba briefly introducing us to the symptoms of thyrotoxicosis? We do understand thyrotoxicosis is a condition of excess thyroid hormones in the circulation. And what would be the mimickers of thyrotoxicosis?
Thank you so much for the kind introduction. and welcome everybody to this symposium on thyrotoxicosis. We all are aware that thyrotoxicosis is metabolic overactivity. There is both autonomic as well as metabolic overactivity because of the raised T3 and T4 levels. So all the symptomatology is mainly related to this increased overactivity. First and foremost, weight loss is seen in especially in long-standing hyperthyroidism, example like in Graves' disease or toxic multinodal goiter. Palpitations, a very common symptom of this. Excessive diaphoresis or sweating, sweaty palm is a common symptom. Tremulousness or tremors is another accompanying symptom. Associated with this is a sense of, patient saying a sense of exhaustion, weakness, unable to tolerate heat. Especially in the weather like this, like we have right now, there is a marked heat intolerance. So all these symptoms basically are.
So Dr. Lamba, we are all not tolerating this heat. So are we all thyrotoxic?
But I think so, a little more than we're not toxic really, of course. But heat intolerance is also one of the major symptomatologies. For example, sitting in the AC and sweating may be a symptom of thyrotoxicosis.
Right.
Air conditioned room.
So what I understood from what you said is weight loss is a very prominent symptom, tremor, palpitations, and so on. So when we talk of weight loss, do we also in the same breath try and say weight loss with preserved appetite or increased appetite?
Oh, yes. Appetite is either increased or normal. So a patient is having a normal appetite or an increased appetite, but still having a weight loss. His appetite there may be a very rare condition like apathetic thyrotoxicosis where appetite and all may be affected badly, adversely. But normally the appetite is normal or increased in this patient.
Right. And a very other common condition that we all come across, diabetes. Would that not also present with weight loss with increased appetite?
Well, you see, agreed, but the commonest symptom of diabetes, if you ask me, is no symptom at all.
Yeah.
That is the commonest symptom of diabetes, whereas with thyrotoxicosis or hyperthyroidism, usually there are more prominent symptoms. In a majority of cases, a large number of cases, there will be some amount of symptomatology. Whereas,
Right.
yes, polyuria, polydipsia, normally polyuria, for example, is not association of thyrotoxicosis. So
Yeah.
this group of symptoms are associated with diabetes than those with disease.
Right. Yeah. So I hope our participants know how to put in the questions in the chat box. Tech team that has been already informed, because I haven't seen any questions in the chat box yet. Right. So we continue with our discussion, and I'm sure the participants will be gaining insights. So can I now ask Dr. Rakesh Sahai? So once Dr. Lamba has suspected someone to have thyrotoxicosis, what tests should we advise? Sorry, please unmute yourself, Rakesh.
Yeah, sorry. Good evening to everyone, and yeah, welcome everyone to this interesting show. And I thank Dr. Professor Subhankar Chaudhary for inviting me to be on this show. So I think as
Rakesh, sorry, let me appreciate your background. It looks lovely.
thank you, sir. Thank you.
Yeah,
So
please.
I think as Dr. Lamba said that there are these situations where clinically you would suspect thyrotoxicosis. So obviously, the next step that we need to do is to investigate for that, confirm that, and the best test to do is do a thyroid profile that includes the T3, T4, and TSH is the usual profile that is done, and that helps us in getting to the to identifying or recognizing the presence of thyrotoxicosis, which is identified by a low TSH suppressed TSH rather, and increase in T4 and T3 levels. The ratio of the T3, T4 also may be useful in understanding what type of thyrotoxicosis is that, because mainly the three situations that we are looking at when you are looking at thyrotoxicosis, we are looking at whether it is from the thyroid gland itself, whether the gland itself is hyperfunctioning, or whether it is because of excessive release of thyroid hormones into the circulation. In a situation where there is some damage to the gland because of inflammation, like thyroiditis, there could be various reasons for inflammation in the gland and release of the preformed hormone. So these are the two broad situations that come to our mind, and we need to differentiate that. And for doing that, the best test is doing a technician scan, which can help us in differentiating between these two scenarios. But this may not be available in every setup. Some of the setups, I mean, if you're practicing in a place where you don't have this, still you don't have to worry about that. You can still use other clinical pointers to differentiate whether it is because of excessive release of thyroid hormone, or whether it is because of hyperfunctioning of the gland itself. So tests like doing the ratio, as I mentioned, about looking carefully at the thyroid profile, and trying to understand whether this ratio is if the T3 levels are higher than the T4, and the ratio is, say, is 20:1, that gives us an idea that the gland itself is hyper functioning. This is a scenario which is often seen with Graves' disease, and so that could be one clue. And then we could have other clues like the clinical examination itself could give us indications. If you have presence of the thyroid enlargement, whether it is a very soft diffuse enlargement as is seen with in Graves' disease, or whether it is a nodular sort of feel, which would be seen with a I mean a multinodular goiter which has gone into hyperfunctioning state. So these are the various scenarios that you can make out. Or if you have got a single solitary nodule, which could be seen with a toxic solitary nodule. So these are the scenarios that you should look for, and also look for apart from the clinical features of thyrotoxicos, which are very obviously made out in the form of a tremor, excessive sweaty palms, tremors in the hands, and then you look for the eye signs. And if there's an infiltrative ophthalmopathy, that again goes in favor of a Graves' disease. So
Right.
these are the situations that we should look for.
So it's a combination of clinical evaluation, examination, or also lab investigations, and T3, T4, TSH is a standard one. Though maybe the average physician may not see, even we as endocrinologists may see very few. As you said, T3, T4 elevated and TSH suppresses the classical feature. So what about if I find that TSH is not suppressed, maybe if it's slightly elevated, 6, 7, but T3, T4 are significantly elevated? Where are we headed?
Yeah. So I think that is a scenario where we should look out for situations where there is either there is a very rare situation where there is a TSH secreting tumor, could be a very rare situation. But the other scenarios are when there is a resistance to thyroid hormone itself. That could be a scenario. So these are scenarios which we see little uncommonly. That may not be very commonly seen. Maybe very rarely, once or twice in a year, we may see such a scenario. But most of the time when we look at it, so I think when you see such a thing, then we should actually look at the report again, look carefully, see whether the report is I mean, we need to recheck on these parameters, look at the clinical findings, and then try to unravel the cause for that.
Now, we have a very interesting question from Dr. Nipin Sharma. I have seen many patients experience better, means they feel better, when the T3, T4 are higher than euthyroid level. Should we consider subclinical hyperthyroidism as mood-enhancing disease? Dr. Srirang, the difficult one.
I think
Yeah.
So thank you so much for having me here, and thank you, Professor Shubhankar Chaudhary, for the introduction. To answer the question first, I think the diagnosis of thyroid disorders has to be made in a clinical context, but solely on the basis of a reliable laboratory report. So it's essentially a laboratory report, but you have to take into account the clinical context. So simply because the patient feels well and he has certain levels of thyroid hormones does not necessarily mean that he's feeling better because the thyroid hormones are slightly elevated. They might be elevated for other reasons. An abnormal thyroid function test does not imply abnormal thyroid function. So the thyroid may be functioning completely normally, and yet you may have a so-called abnormal thyroid function report. For example, a woman who is on an oral contraceptive, she might have an elevated T3 or a T4 with a normal TSH, but that is simply because of increased thyroid binding globulins. So one should not go, take the clinical context into account before making a diagnosis of thyroid disease, but rely on a good lab report. That is what I would say.
Yeah, so lab is very important. And the other part also, maybe with due respect to Dr. Nipen Sharma, maybe he would have seen a few patients where they felt better with the T3 and T4 being higher. But I don't think we can generalize that if your T3 and T4 are higher, then you'll feel better. So I don't think you can generalize on that point. So we come back to Dr. Srirang. So we have already heard about, sort of had a reference to the different causes for thyrotoxicosis. So what are these, and which is the commonest? If we see one, which is the one that will first strike our head? So what can we sort of pass on to our physician colleagues?
So I think first the terms thyrotoxicosis and hyperthyroidism need to be placed in their context because they are often used interchangeably. Now, this is not some hair splitting that I'm doing because this has therapeutic implications. So basically, thyrotoxicosis is an all-inclusive term which denotes that the tissues are exposed to excess quantities of thyroid hormone. It's a generalized term, and it includes a subset of patients where the thyroid gland itself is the source of the excess thyroid hormone. And when that happens, that condition is called hyperthyroidism. So all hyperthyroids are thyrotoxic, but all thyrotoxics are not hyperthyroid. This is important therapeutically because antithyroid drugs are to be used in a hyperthyroid state and not necessarily in a non-hyperthyroid thyrotoxic state. So essentially, conceptually speaking, I think there are four broad categories where you can have thyrotoxicosis. The first, which is most common cause of hyperthyroidism in general, is when the thyroid is being stimulated by trophic factors, like, for example, a TSH receptor antibody, which is what happens in Graves' disease. You could also have an autonomous release of the thyroid hormones constitutively by a solitary benign adenoma, which is called a toxic adenoma, or you can have multiple nodules finally causing autonomous release of the thyroid gland, which is called the toxic multinodular goiter. Now, all these three conditions constitute hyperthyroidism, but between the three, the Graves' disease is the most common, but it also depends on the clinical context. So, for example, Graves' disease would be relatively more common in a younger population. But if you look at elderly populations, then maybe a toxic multinodular goiter could be more common. And also that is probably relatively more common in areas of iodine deficiency. So if you have an elderly patient coming from an area of iodine deficiency, chances are that toxic multinodular goiter is more common than Graves' disease. But you can have other causes of thyrotoxicosis which are not hyperthyroid, and that could be simply release of preformed hormones from the thyroid gland as a result of autoimmune insult or mechanical insult or chemical insult. And the most common cause maybe in our country would be after delivery, after postpartum period. About 5 to 7% of women develop a transient thyrotoxic phase called as postpartum thyroiditis. And then finally, you can have an exposure to extrathyroidal sources of thyroxine, which could be either endogenous, which is pretty rare, like struma overi, or metastatic functioning thyroid metastasis, or there could be an exposure to exogenous sources of thyroid hormone. And most common, which is rather common, is an over-treated hypothyroid person who's being given thyroxine in excess. And that would be a thyrotoxicosis factitia, which I believe probably would be arguably the most common cause of thyrotoxicosis, though it doesn't come as hypothyroidism, but overtreated hypothyroid patients. Or sometimes patients taking so-called tonics or weight loss medications unknowingly containing thyroid hormones. That could also be a source of exposure to a thyroid hormone, or patients surreptitiously taking thyroid hormone for whatever reason. So all these are the common sort of reasons or causes for thyrotoxicosis. But Graves' disease in the younger population, toxic multinodular goiter in the relatively elderly patients with iodine deficiency, thyrotoxicosis factitia, exposure to excess levels of thyroxine in a hypothyroid individual, and finally postpartum thyroiditis or sometimes subacute thyroiditis due to viral infections are some of the common causes of thyrotoxicosis in our country.
Right. So that's crystal clear. Now we have Dr. Ritesh Agarwal answering, maybe providing explanation through some questions that are there in the chat box. First of all, we do know iodine is an essential component of thyroid hormone, and there is a concern that iodine excess may lead to excess thyroid hormone secretion. So the question Dr. A.K. Singh puts is, any comments on low salt alternatives used commonly nowadays? So the assumption is those low salt alternatives may not contain iodine, and so whether they would be better to use, which he has not explicitly mentioned, but I suppose that's what he has in mind, in patients who have got overactive thyroid, should we be going for these other salt alternatives in order to avoid the exposure to excess iodine?
Uh, Thank you, sir, and good evening, all the delegates. Sir, as we know, as Godbole sir said, the most common cause of toxic multinodular goiter we are getting in the situation of the iodine deficiency. Once the toxic multinodular goiter are developed, they are mostly autonomous. So once we give the iodine sufficiency diet to the patient, there is more increase or aggravation of the thyrotoxicosis or hyperthyroid feature to that group of patient. So if we will decrease the iodine supplementation to that group of patients, then the symptoms of or the formation of thyroid hormone has reduced. So I think if there is an alternative of low iodine salt in that group of patient is available, that will act as a therapeutic beneficial to the patient in terms of dietary intervention, then we will go for the anti-thyroid drug therapy or any other modality to control the hyperthyroidism.
Right, except that maybe they are not so widely available, and they would also be much more costlier than the standard common salt that one uses. Right, and we have another question, interesting one from Dr. Kaushik. So I'm reading out what is written. I have read that biotin may interfere with thyroid function test. Now, many supplements in market contains biotin. Please shed some light on it. When to advise test if patient is on biotin-based supplements.
So,
First of
yes,
all, first of all, we need to suspect that. When should we suspect that this is just a laboratory abnormality, not a clinical condition? And then, of course, the rest of the question. Yes, Dr. Ritesh.
so mostly, sir, biotin-rich supplementation are coming for the hair supplementation, where for the hair loss or for any hair-related issues, the biotin concentration is more. And we also says that those group of patients who are taking biotin, they have a falsely positive blood parameter of high T3, T4 in that group of patients. So
And also
Low TSH.
immunogastric acids will give you a falsely low, sort of low TSH, exactly as it would happen in thyrotoxicosis.
So whenever we are seeing a patient of euthyroid symptomatically, but biochemically we are seeing reports of this with some form of a hair loss or some form of either extra supplementation if the patients are taking, then we can think of the biotin supplementation or the biotin interference in the biochemical test.
Right. And
In fact,
many.
in fact, I would say, sir, that the previous question which we had, where one of the participants asked us whether, when you have a higher T3, T4, and he has seen some of these patients who had been feeling better, it could be one of these scenarios.
Yes.
Yes, yes. So, but the important point is patients would not generally come up with a sort of something written on the forehead, I'm taking biotin.
Yeah, we'll
Only
have to look
if
at it.
you ask, and then yes, maybe yes, I heard advised, and then they would recall yes. And then also there's so many preparation. I can't remember the names of all uh, uh,
Yeah.
the product names. So maybe many a time on for these, I have to take a recourse to our Google friend and then find out actually what this contains. I don't know what about you. Maybe you can remember more names. I don't know.
So
Right.
mostly euthyroid
Yes.
doesn't come with this type of biochemical report. We can have a differential diagnosis of supplementation, which can cause the false positive report.
So this is a very important issue that Dr. Kaushik has raised. Thank you very much. So now can we come back to Dr. Lamba with his sort of clinical experience over the years? So, but I'm a very busy practitioner, so I'm not an endocrinologist like you. So I don't have much time for one patient. So what are the essential clinical examination that I should do?
You see, for any patient or for any general practitioner, when a patient gives you symptoms and signs of hyperthyroidism or thyrotoxicosis, the first and foremost thing you look at is his pulse. Because one of the commonest complications of thyrotoxicosis is atrial fibrillation. Tachycardia is common, but atrial fibrillation may be also present as a main symptom. To start off, we're looking at the weight, the pulse, the blood pressure, if there's systolic hypertension, and general examination where you could see the tremors and sweaty palms as mentioned earlier. These are very common symptoms of your patient. And don't forget to examine the thyroid gland. A proper thyroid palpation is extremely important. In conditions like we mentioned, subacute thyroiditis or postpartum thyroiditis, the thyroid gland may not be palpable at all. Whereas in Graves, you can expect a diffuse goiter, and in a multinodular goiter or in a solitary nodule, you expect a nodular goiter. A proper thyroid examination palpation is an extremely important step in this. At least this is the minimum examination which you must perform in a patient with suspected thyrotoxicosis.
Right. And of course, even the thyroid gland may not be very big, but in subacute thyroiditis, typically it's quite tender. And that can also be flitting, maybe for a few days on the right side, and then it goes to the left side. And there may or may not be diffuse enlargement, there may be nodular enlargement. So tenderness is also something maybe we should
I
try.
think that in subacute thyroiditis, tenderness may be symptom. As a matter of fact, PO is one of the differential diagnoses of subacute thyroiditis may present as a pyrexia of unknown origin.
Absolutely.
And
Right.
so that's one of the differential diagnoses of that.
So why while we are on this issue, yeah, sorry, Dr. Lamba, you had something more?
Yeah, also ophthalmopathy and dermopathy. Dermopathy is quite uncommon, but
Yeah.
ophthalmopathy is a very common accompaniment. And we should definitely look at the eyes and see if there's exophthalmos or any eye involvement in a patient with thyrotoxicosis.
Right. So while we are on this issue of subacute thyroiditis, we have Dr. Sharma asking this question: how to treat post-viral infection thyroiditis? Do steroid work well in such situation? If yes, which steroid, what dose, and maybe how long? Dr. Lamba, would you like to continue?
I personally am not very much in favor of using steroids for my patients with subacute thyroiditis.
Okay.
By and large, I avoid steroid usage in a patient. But in some situations, special situations, when there's a lot of pain and swelling perhaps, and a lot of degree of inflammation associated with hyperexia, a short course of steroids, perhaps I would like to give, and I'd like to give. I normally will only go for prednisolone in doses up to 30 milligrams,
Right. So,
and take it off within 10 days or so. But I will give very short course of it. I don't like to give long course of the steroid. And by and large, as I said, I tend to avoid it. By and large.
so,
I would
so, so, so,
tend to
what do you do? Don't you give any symptomatic treatment to the patients?
symptomatic, yes. NSAID, perhaps a beta blocker like a propranolol, that I give. You see,
Now,
because
anti-inflammatory, if they have fever and so,
NSAID, like that, any of the non-steroidal analgesic drugs, this is what I normally usually prescribe to these
right. So I think all the endocrinologists
people.
would
Most of all,
agree.
I reassure the patient. I
Sorry?
reassure the patient that it is such a self-limiting disease.
Yeah.
If you treat it, it takes 3 months. If you don't treat it, it takes 90 days.
Right.
So that is the major, you have to reassure the patient that over a period of time, the disease will subside by itself.
Right. So, would all the other endocrinologists agree on this point?
Absolutely.
Right. The only point where I maybe differ slightly in my clinical practice, I would initially try and use NSAIDs, and then only if it doesn't give enough symptom relief, then only go for steroid. But what I have found is a 10 days course, quite often once you stop, the symptoms come back. So usually I tend to give a little bit longer, and there have been rare instances where I have had to use steroids for up to 3 months, but mostly they subside within 4 to 6 weeks. So usually I would use steroids for a slightly longer period. Right. And so I think this is the topic that we are discussing today is of importance and interest to our clinicians. So they are putting in important questions. So uh, Dr. Parmar, is it okay to prescribe T3, T4 to athletes who are having hypothyroidism? Is it allowed in doping tests? Do medical certificate allow him to participate in tournaments? I think this is, would anyone like to take, or actually, what does Dr. Parmar actually have in his mind? I don't know. I mean, definitely those who are having hypothyroidism, we do treat. Standard treatment is with T4, thyroxine, but there is a small niche possibly where patients may gain from adding T3 as well. Maybe I don't use that often, but there are some studies, French studies and all, which have shown use. But of course, not just for athletic performance, we never advise thyroid hormones to be treated. And those medical certificate element, I have not understood if someone is on thyroxine, he or she is jolly well should be able to join any tournament. Right. So while we continue, so we have understood the causes, we have understood the symptoms, we have looked at the physical examination. Now the issue of iatrogenic thyrotoxicosis, which has been mentioned, and Dr. Sahai has also mentioned. So is that common? Is that important to consider? Dr. Rakesh Sahai.
Yeah, so I think what I would say is that I mean, if you look at the practice a few decades back, when getting a thyroid test was difficult, people were started on a standard dose of thyroxine. Replacement dose was never considered to be less than 100 micrograms, and when somebody had a thyroid surgery, they always got maybe two tablets of thyroxine or maybe more than that. So this was a scenario where it was difficult to check for the thyroid hormone levels and check for the TSH to know whether the replacement was sufficient or there was overdoing of that. So that there, I think that was a scenario where we see a lot of this. Nowadays, we don't see that much, but yes, we still see, as Dr. Godbole told us, that that's one of the important causes, and probably he said that maybe the most commonest scenario where we see this, but thanks to the availability of tests, we are able to identify that, and we are able to And the other point I would say is that thanks to the availability of all the strengths of thyroxine that are available in the market, we are able to, titrate to the appropriate dose and avoid this problem, which used to be very rampant earlier.
And does that actually carry risks?
Yes,
Iatrogenic.
I think what we need to understand is that at least in the elderly population, it does increase the risk for atrial fibrillation. It increases the risk for thyrotoxic. I mean, for osteoporosis in older women with thyrotoxicosis who are I mean, with hypothyroidism who are over treated with thyroxine. These can be the two important risks that we should always keep in mind.
Right. The other area where actually we deliberately possibly cause some amount of thyrotoxicosis is following a thyroidectomy and with or without radioactive iodine ablation in differentiated thyroid cancer, where we keep deliberately the TSH, maybe not really in the thyrotoxic range, but on the lower side.
On the lower side, yeah.
Many patients I have seen are running thyrotoxic blood levels, uh, and sometimes it's a push and pull between the medical oncologists who want to give more, and we as endocrinologists possibly want to give less. But that's another area, right? So can we
I
have
think
Dr.
there also, I just want to make one comment.
Yes,
There,
yes,
what has happened nowadays is that with the availability of these third generation TSH assays, it's easier to look at the lower ranges and titrate it more appropriately. And also the newer understanding about risk stratification, and those with lower risk, we tend to not overdo the thyroxine supplementation. So
right,
those are 2 points I just wanted to mention.
right. So we come back to Dr. Godbole. So this is a question from Dr. Ishwar Prasad. So this is a practical issue that is raised. So he has had a patient of hypothyroidism treated with radioactive iodine 6 months back. TSH is now in the hypothyroid range, and the patient requires small doses of thyroxine, but heart rate continues to be high even with beta blocker. How to manage tachycardia in this patient? She says she feels better compared to 6 months back, I suppose.
Well, again, every complaint that a patient of thyroid dysfunction may be having may not necessarily be attributed to the thyroid dysfunction itself. There could be other causes for tachycardia. If the thyroid function report is completely normal on a given dose of thyroxine following radioiodine, and in spite of a normal report, the patient has tachycardia, I believe that the tachycardia is not because of anything to do with the thyroid. One has to look for other causes. Please do not attribute every symptom that a patient with thyroid dysfunction has to the thyroid dysfunction itself. Please remember that patients could be having other disorders as well. So most likely this patient has another disorder which is responsible for the tachycardia. It may just well be sinus tachycardia, maybe his blood pressure, maybe his other causes, maybe there's a white coat tachycardia, we don't know about it. Now speaking of tachycardia, and Dr. Lamba was also mentioning pulse rate, I think it's important to know that in thyrotoxicosis, the resting pulse rate is more than, so if a relative of the patient is fairly intelligent, you could ask them to take the patient's pulse when they're asleep. And if that is more than 90, then that is significant. A resting tachycardia is very significant, not the tachycardia which an anxious patient may have when he attends a clinic or looks at a new doctor. So there could be various causes for tachycardia, but in this patient, I don't think thyrotoxicosis, the past history of thyrotoxicosis is responsible.
Absolutely. So now we were talking about Graves' disease or grave disease, whatever way we call it, being the commonest cause of hyperthyroidism that we deal with. So in terms of diagnosis, Dr. Rakesh Sahai has told us about the thyroid hormone measurements. So we now have access to thyroid TSH receptor antibody test. Maybe not widely available, but at least in the major metros, it's available, and even through those bigger labs which have facilities of collection from different smaller places also. This can now be available, though again the cost is still a bit on the higher side, not affordable for everyone. So would you like to use this test for every patient where you suspect grave disease? And also in management, does it help you? Or didn't I put it to anyone in particular? Maybe
Yeah.
Dr. Ritesh. Dr. Ritesh.
So rightly said, sir, we have already discussed about the different tests already. Sahay sir has also said, but TSH receptor antibody, especially stimulating antibody, it has some role while we are seeing some atypical cases of thyrotoxicosis to give the diagnosis of Graves' disease. And it has some prognostic importance also. Like if I will say, it has some relative importance in the recurrence of Graves' disease if we will measure the thyroid receptor antibody. And if it comes out to be very high, there is a very high chance of recurrence after the antithyroid drug treatment has been given. It has some diagnostic importance also, while especially in the first trimester of pregnancy, if we are doing to differentiate between the gestational thyrotoxicosis or hyperemesis gravidarum thyrotoxicosis or the Graves' disease. So it has some diagnostic purpose also. In the late trimester of pregnancy also, if there is high titer of thyroid receptor antibody, there is a high chance that the neonatal thyrotoxicosis risk is also high. And especially those group of patients who have high thyroid receptor antibody, subacute thyroiditis, Graves' disease, they have higher risk of thyroid receptor. So some form of uh, therapeutic benefit, some form of diagnostic benefit, and
Sorry, Dr. Ritesh, I didn't understand. In subacute thyroiditis,
subacute thyroiditis, especially where there is unilateral exophthalmos is there, euthyroid thyrotoxicosis is there. In that cases, we may go to the diagnosis by using the TSH.
So in your clinical practice, do you use it, or you feel there isn't a great role for it?
Mostly, sir, I will do in my practice, especially in the first trimester of pregnancy, those who were not diagnosed with hyperthyroidism without symptoms comes with hyperthyroid reports. I will do a thyroid receptor antibody to give the diagnosis to the patient. And especially a normal thyroid report with exophthalmos, like euthyroid with exophthalmos, to find out the cause, I will do TSH receptor antibody in my practice.
Right. So the other endocrinologist, quick word, where would you use TRAB these days? Maybe
Yeah, I think one point that he mentioned about understanding the risk of recurrence of thyrotoxicosis when you're deciding to stop antithyroid medication, whether to stop, whether you're confident to stop it or you want to continue that at a smaller dose, is a scenario where you can use this test to decide on that.
I
Right.
also agree with that. I have used it very often in this context when we want to stop your, after giving, say, a euthyroid period of a year and a half, and now you want to stop numericazole or carbimazole therapy. A guide, it becomes a little help if you can do this
Yeah,
antibody.
that's exactly what Dr. Rakesh also said.
Sometimes we use it.
Yeah, but having said that, I must also share my experience that even if the test has now become negative and I have now stopped the antithyroid medication,
You can
there
still
have been several instances where the disease has come back. So
Agree
I
with
think
you. Okay.
our discussion, yeah, so I think we need to have a clear discussion and tell them that this does not guarantee that you will not have a recurrence, but of course the chances are less if we stop at a time where the antibody is negative. Right. So we have another question now. Dr. Batra, almost 1 out of 15 patients of hyperthyroidism diagnosed with atrial fibrillation. So maybe that's, yeah, Dr. Lamba was only pointing that out. So you could well have. I usually refer them to cardiologists if they have atrial fibrillation. They treat them with beta blockers. However, hyperthyroidism associated with thrombotic stage risk possibly. Should we treat them with anticoagulant medication? How long till reports are normal or lifelong? Maybe I think we should have a cardiologist on board to answer all those questions. But would anyone like to take up this question? So
Well,
whether
I think
yeah,
a younger individual, I would not think of anticoagulating such an individual. I would rather look at getting them to euthyroid state and looking for the atrial fibrillation resolving. If it is not resolving, then maybe you will take a opinion of a cardiologist to decide on the anticoagulation. But I generally feel that treating the thyrotoxicosis is going to provide us benefit.
yes, because we here have a sort of reversible cause, but if the process has been long standing, then even by rendering the patient euthyroid, one may not revert the atrial fibrillation. Then of course we need to take the help of our cardiologist, how best to go about it. Right. So a very important question for Dr. Lamba. So I have got this patient whom I diagnosed as grave disease. Maybe I would have these days with the availability of TRAB, maybe I do that. Maybe Dr. Ritesh Agarwal does not do, that's fine, but we all have come to a conclusion in our minds that this is patient with grave disease. So how do you sort of, what is the initial conversation with the patient or the family? Do we straight away write neomarcazole or what do you do?
Oh, every patient of mine, I offer them the choice. I really think there are two choices in front of you.
But
Either
but,
you have,
but doctor, but in your practice, I don't know in Mumbai what do they say, but in my Kolkata, shall I say 6 out of 10 would say, doctor, I have come to you. You tell me what's best for me.
is
That's
it,
why I'm paying you the fees for that.
but I can explain to them that we have got two available choices. If you one is give a carbimazole therapy, as we all know, it is a long-term therapy, and we know the chances of remission not 100%. The second point is this is a short-term therapy where the side effect is with hypothyroidism, which you have to take replacement doses for life. And I've seen that most cases opt for, in my case, they don't opt for radioiodine therapy, they opt for carbimazole therapy. But a few do opt for radioiodine therapy, especially I insist that to the ladies who are keen on pregnancy. Young ladies, for example, if you are to be, and they don't have a child, but they are in the child bearing age group. So I said that if you take radioiodine, you within 6 months or so after taking iodine therapy, you could plan a pregnancy without any danger. So in those cases, I tend to be a bit more persistent about radioactive iodine therapy. In that particular subgroup of patients who are keen on pregnancy in the subsequent time and right now don't have any child. So by and large, this is the choice that is. But I give them a choice to both of them.
What about surgery?
Surgery, yes. Surgery comes in when there's ophthalmopathy. Once there's ophthalmopathy, then the coil of radioactive iodine goes out of the choice. So either you have carbimazole therapy or surgery. So it is in the rare case, it's quite a rare case where we have long-standing thyrotoxicosis who's got grades of ophthalmopathy where surgery may be considered. But by and large, it is a very small percentage of cases where surgery comes into play.
Right. I agree with Dr. Lamba. Rather, my experience is also similar that once I've discussed the options with the patient, most of my patients at least say, no, doctor, I like to be treated with medicine. I do not know whether it's something that I tell them which sort of drives them away from radioactive iodine. I don't know. But would the other endocrinologists experience sort of share their experiences? Dr. Shahai?
Yeah, so I think, sir, I also would tend to agree with what you're saying that most of the patients would prefer medical therapy. They would like to be on the medication and antithyroid medication for some period of time. But after some period of time, I see the acceptance becomes a little better after 6 months or 1 year of being on the antithyroid medications. then I tend to discuss that a little more in detail at that point of time, because what I've seen over the years is that the in the initial phase, most of them are not very keen on going for radioactive iodine immediately. And what I've also, I mean, what I would also agree with Dr. Lamba that, in some scenarios, like a woman who's not planning to conceive immediately, but is is planning for conception after a year or so, that's the best time to explain to her about radioactive iodine therapy, and that becomes the best form of therapy there, because then we are sure that when she's planning for pregnancy, she's euthyroid.
Right. Dr. Godbole?
Well, I give the choice to my patients, but if they ask me what to do, then if I'm not certain about the follow-up of the patient, if I'm not certain about the compliance of the patient, then I would rather insist on radioiodine, because anti-thyroid treatment, patient needs to really follow up regularly, needs to approach the doctor and be compliant with the medication. So if not, I'm not confident about these two things, I would rather ask for radioiodine. The other thing is radioiodine, the patient spends more at that point in time. But if you see the, especially a person staying outstation, spending some time traveling and coming to you, spending money on that, as well as spending money on the test over the next 2 years or 2.5 years, over a period of time, I think it becomes more expensive for the patient to take anti-thyroid drugs, especially if they're outstation and, staying far away. So in such cases, again, I would rather tend to go towards radioiodine. And again, as was mentioned, if a pregnant a person, a lady who wants pregnancy, but not immediately, maybe after a year or two, I think it becomes easier to give radioiodine finish off. And the other scenario is when patients keep on requiring higher and higher doses of anti-thyroid drugs and don't seem to come under control. Then I pause in between a course of anti-thyroid drugs midway and suggest radioiodine again to such patients.
Right. And many of the patients that we see, at least that I used to see in the government hospital setting, where patients, again, because of affordability issues, they do not take the anti-thyroid medication regularly, and maybe they get admitted with not clear crisis, but very poorly controlled thyrotoxic states, sometimes with atrial fibrillation. And there also, we tend to sort of immediately use radioactive iodine to get them under control, and then of course have to treat for their hypothyroidism. Dr. Ritesh, what so let's say your patient agrees to radioactive iodine. So do you just refer to the nuclear medicine, or do you define that this patient should have 10 millicurie or 15 millicurie or whatever? What is your practice?
In our practice, what we do, mostly we will not say the dose to the patient, how much the patient require the millicurie. The patient will be referred to the radioiodine therapy nuclear medicine department, where they initially do a radioiodine scan. By seeing the intake of the thyroid gland, they will give 5 to 10 millicurie to the patient with a contention that the patient will go into hypothyroid.
But this uptake-based dosage, I think it's largely being replaced by a fixed dose. I mean, and again here, I think we are still not doing the best possible for the patient, in that we are converting one disease into another, hyperthyroidism into hypothyroidism, and so higher doses are being used more often. Nonetheless, okay, so now the patient, let's say the other scenario where the patient wants to have medical treatment. So Dr. Sahai, so how do you explain how long to take, or how much to take, and the adverse effects? How do we make them aware of the adverse effects?
Yeah, so I think we need to discuss with the patients about the fact that most of them require this therapy for at least a year or a year and a half before they go into remission. Those who go into remission, they would still require it for about a year or year and a half. So that point has to be explained to them, so that they are sure. Otherwise, what happens is that once they may get a normal report after say 2 or 3 months, they may feel that they just need to stop the medication, and they would go back into the thyrotoxic state. So that is one thing that has to be explained. And the other important point is about the side effects. Although we have many, less sort of milder side effects like pruritus and all that may be very common with the thyroid medications. It may happen with thyrotoxicosis also, but that is not a major concern. But our major concern is somebody having a pancytopenia developing because of these medications. So that point has to be explained to them most of the time I would tell them that, if they experience fever or sore throat, then they should immediately come back and also get a CBP done. That would help us in understanding, identifying this early. So this is something which we need to explain to our patients, and that is some because this is a idiosyncratic reaction. It's not dose dependent. It can happen to anybody. It is uncommon, but can happen. So we need to make them aware about this. And the other uh, adverse effects would be, the hepatic effects like hepatotoxicity with PTU, which causes hepatotoxicity, while carbimazole and neomercazole and methimazole may cause more of cholestatic jaundice. So these are the major adverse effects we are worried about. There could also be some degree of vasculitis and all that happening with PTU. So that is another thing that has to be kept in mind. So I think these are all the adverse effects, but the major ones that we need to sort of the most important thing that we need to make our patients aware is about the pancytopenia. If that is to happen, and that has to be picked up early, and we need to stop the medication. We can't go to the other one also. We would stop the antithyroid medication, think of other alternatives, think of radioactive iodine in such scenarios.
Right, Dr. Ritesh, uh, Dr. Rakesh Shah has said that he can give anti-thyroid drug for 6 months, 1 year, maybe 1.5 years. Now, uh, before incidentally, I just got a message a short while back, of course, that 1,200 doctors from across the country have joined to learn from you all.
Oh.
So, in front of all of them, I may actually admit that many of my patients are on carbimazole or methimazole for the last 5 years, 7 years, 8 years also. So, Ritesh, would you write me off as an endocrinologist?
Yeah,
If
sir.
the patient gets
Definitely. Most of the time we read from our book that after 1.5 year, the most of the patient, 30 to 40% will go into remission. But after that, if they will not go into remission, then they have a options of again radioiodine ablation or the radioiodine therapy or the continuation of the low dose of antithyroid molecule. So most of the patient in our practice also, they will prefer to continue the low dose of medicine over the radioiodine ablation. So we can continue if there is no remission with this antithyroid drug molecule. But as Rakesh Sai sir has rightly said, it is a idiosyncratic reaction. It can happen at any point of time. So we have to be careful while continuing this group of medication.
So just
Uh,
putting one point in perspective, I mentioned 1.5 years, saying that, that is the time when we would rethink about it, if we need to, go for other options. And that's where we would seriously discuss with them about other options, because many times, as I mentioned, that in the earlier days, they would not be very keen on going for radioactive iodine therapy. Having been on medications for a year or year and a half, then they are more likely to be ready for going for radioactive iodine therapy.
Right. So, as Dr. Shahai mentioned, that we have three options before us if we decide to use anti-thyroid medication. One is carbimazole, which we have been using for a long time. Then methimazole also has become available to us. PTU, propylthiouracil, is also available, but not so widely available. So, Dr. Godbole, do you have any choice? Which one do you use? And what's the difference between these three?
Between methimazole and carbimazole, there is little to choose. There is certainly a difference between methimazole, carbimazole on one hand and propylthiouracil on the other hand. I would say propylthiouracil should not be used except within the first 16 weeks of pregnancy, if at all. But otherwise, the drug of choice should be methimazole or carbimazole. Propylthiouracil certainly should never be used in children. because the risk of hepatotoxicity is far greater in children. Propylthiouracil, the main problem is hepatotoxicity. It is very often dose dependent, and it can cover the whole spectrum of asymptomatic transaminase elevation to fulminant hepatic failure. And the mortality in acute hepatitis is pretty high with propylthiouracil. So one has to educate the patient about, appearance of jaundice, dark colored urine, or light colored stools, or pharyngitis or fever. All these things, the patient has to keep a watch on that. Whereas with methimazole, carbimazole, if at all you're likely to get cutaneous reactions, if at all you get hepatotoxicity with the methimazole, carbimazole, it's likely to follow a cholestatic pattern. It is usually mild and it resolves after the drug is withdrawn. So also with propylthiouracil, the type of hepatic pattern that you get is a parenchymatous hepatic involvement rather than a cholestatic involvement. And it is far more serious compared to methimazole or carbimazole. So I would prefer methimazole or carbimazole between the two, not propylthiouracil. Even in pregnancy, I would only up to 16 weeks maybe. After that, again, switch to methimazole or carbimazole. And even for breastfeeding, it's preferable nowadays to use methimazole, carbimazole rather than propylthiouracil.
Right. So I'll give you two scenarios. One is a patient diagnosed with hyperthyroidism, and as part of the initial evaluation, we often do also thyroid function test, a liver function test, and it shows some elevation of the liver enzymes. The other would be a patient who is on an antithyroid medication now presents with jaundice. So what are our approaches? Maybe in the first case, when patient at diagnosis has some not grossly deranged, but mildly deranged liver function test, what do you do? Is that a contraindication to use of the antithyroid drugs? Dr. Godbole.
So mild elevation in liver enzymes can be a part of the thyrotoxicosis itself. And as many as about 14 or 15% of patients with thyrotoxicosis can have a cholestatic pattern, a raised alkaline phosphatase, simply as a part of thyrotoxicosis. And the alkaline phosphatase elevation may not necessarily be coming from the liver, it could be coming from the bone. So a mild elevation per se in an asymptomatic patient, I don't think is a contraindication per se for antithyroid medication, but one has to be more careful, because if there is hepatotoxicity which is likely to develop, then that is more likely to develop within the first 2 or 3 months of the treatment. So you have to alert the patient to the various symptoms which I just mentioned, maybe do a hepatic function test, particularly in the first 2 or 3 months. Whereas if a patient has been on antithyroid drugs and develops jaundice, well, I'll be most reluctant to continue with the antithyroid drugs. I will stop. I will strongly advocate an alternative form of therapy, maybe radioiodine in such a patient,
Right.
especially if it is a parenchymatous hepatitis. A cholestatic hepatitis, a patient is on carbimazole. Usually it's mild. Again, I say that very often it is asymptomatic. So merely a rise per se, that is not really a contraindication to stop. But if it is persistent and patient has symptoms, and you said the second case had jaundice, I would certainly not continue antithyroid drugs.
No. So Dr. Ritesh, so in this second case, let's say the patient is thyrotoxic and needs some treatment. You cannot directly maybe go on to radioactive iodine treatment, and neither is it so widely immediately available everywhere. So how do we tide over this patient?
So we have some of the molecule which has antithyroid property also. We can give lithium therapy to the patient with a dose of around 300 to 600 milligram, maximum 1200 milligram per day, which has a mechanistic action of decrease the conversion of T4 to T3 and improves the symptoms. In other way, if the patient has symptoms of thyrotoxicosis, but drug-induced hepatic insufficiency is there, then we can have other options of symptomatic relief with beta blocker, or we can use steroid to give the symptomatic relief to the patient till we can prepare the patient for the radioiodine therapy.
Right. Now, let's say another very important area, maybe we have touched on it as we come gradually to the end of this edition. And my latest figure that has been provided from Intas side is that 1,548 doctors have joined and hopefully benefiting from this discussion that we are having amongst ourselves and also with them. And we are trying to answer as many questions as possible that they're putting in. So, Graves' disease in a young married lady. So, what are our sort of suggestions to them? And if they want conception, what do we do? So, maybe Dr. Lamba, would you like to take that up?
As I said, if you are keen on pregnancy and you don't want a baby immediately, perhaps you can wait for a year or so. I would advise them to go in for radioiodine therapy in such a couple.
Yeah.
But I've also seen patients, in my experience, who are against radioiodine therapy. Even after advising them, they go on methimazole or carbimazole therapy. In that case, you, like you rightly said, that in the first trimester, if they do get pregnant, we use PTU, and then from the second trimester onwards, we switch over again back to carbimazole or methimazole. So that is their choice. But by and large, in such cases, I do advise to go for radioactive iodine therapy in these cases.
Okay. Dr. Rakesh, sorry, Dr. Ritesh, sorry. Ritesh, so your patient, whatever the doctor may or may not have advised, has been on carbimazole and now comes to you with pregnancy. Now what do we do? Do we say terminate the pregnancy?
No, sir. As Godbole sir also earlierly said, in the first trimester we will give PTU, or in the next second, third trimester we can continue with the carbimazole and methimazole.
Yes,
And
sir. So your patient is already on carbimazole, let us say, and she has conceived and she's in the first trimester, let us assume. So do you want to now change back to PTU and then again come back to carbimazole? I mean, why do you do that?
Yes, sir. Most of the time I will continue, but the guidelines and literature, what they said about the increase in risk of teratogenicity with the methimazole and carbimazole in the first trimester, and the risk of hepatotoxicity with the PTU, where it did not cross the blood placental barrier. So in the first trimester, there is a significant mild beneficial effect of the PTU crossover the carbimazole and methimazole. But if there is no side effects and no hepatotoxicity risk is there, we can continue carbimazole or methimazole. But in my practice, I changed the carbimazole methimazole to PTU in the initial third trimester up to 3 months of the pregnancy. Then I will again change to carbimazole and methimazole. There is no need to terminate the pregnancy during this time.
Right, yeah. So I think that's the standard. All guidelines would suggest that, but I personally feel that the evidence also is not. If you look at it very carefully, it does not very strongly suggest that there is a whole lot of difference in those who have been exposed to methimazole or carbimazole versus PTU in the first trimester. The eventual, the congenital malformation or whatever the complications rate probably are not very different in real world evidence studies. But anyway, that's standard recommendation, of course, is to use.
Depends on the dose of methimazole, I think, or the carbimazole. If the dose is small,
Yeah.
virtually insignificant quantities will cross over. So it doesn't matter.
Right. Finally, Dr. Sahai, before we wind up, maybe we have one more question, but which is largely been answered before. So, patient has delivered, has been on antithyroid medication. So, is she supposed to lactate, or should we say, no, that's wrong? You cannot breastfeed your baby. What do we say?
No, we should advise her to breastfeed her baby.
And stop antithyroid drugs?
No, because what we need to look at is that what happens generally in pregnancy. One point which I want to like to highlight, which was not discussed here, was that generally when we look at hypothyroid situations, the dose tends to increase during pregnancy. Whereas when you look at hyperthyroidism, you see that the dose requirement actually comes down during pregnancy, and immediately after delivery, we can expect actually a rebound increase in the requirement for antithyroid medication. So the antithyroid medication will be required, but we should still encourage breastfeeding. And there was a time when we used to think that PTU may be better when we were not aware of the hepatotoxicity of PTU, but now with the evidence about the hepatotoxicity, we do not recommend PTU in that scenario. We would still recommend them to go with carbimazole or methimazole, and use timing of that also may be very important, because the although we use it once a day, it is in circulation for a short period of time. So maybe you can advise the patient that after breastfeeding, then take the medicine, and it may be in circulation for a short period of time. That is something which we can practically give them advice. But nevertheless, we need to encourage them to continue breastfeeding, and the need for antithyroid medication will be there.
And do we need to monitor the newborn with thyroid function test?
That may be something which we may need to do, because we know that it is going to be excreted in the breast milk.
Yeah, but of
It
course,
will
if
be
we
less, but carbimazole may be there. So we may have to keep an index of suspicion for that, and watch out and monitor where required.
Yes, I mean, in today's medical legal age, possibly we should advise, but we do understand that if we use relatively small doses, 5, 10, even up to 15 milligrams of carbimazole or methimazole, probably the amount that's excreted in the breast milk will not affect the baby's thyroid function. Right. So we have two quick questions and then we wind up. One is maybe Dr. Godbole. Dr. Sahai has already referred to this. So in some cases, we don't have the name for this question, who has put this question. In some cases, both T4 and TSH are higher than normal. How can we treat them? Dr.
Well,
Dr. Ames Raju from Vizag. Yeah.
So if both T4 and TSH are high, I would first do a free T4. I would look for medications which can increase the thyroid binding globulins and hence cause a rise in the total T4, whereas the FT4 may be completely normal. Well, obviously, if the TSH is high, it again depends how high and what's the age of the patient. If the age of the patient is 70 or above and the TSH is 6 or 7, I'm not going to get bothered. So please remember that the normal of TSH is age dependent, that we very often fail to realize. But I presume that this patient, if it is a young patient and the TSH is say more than 7, I would certainly then treat the patient as a hypothyroid patient. But very often I find patients being treated with thyroxine for a TSH of 4.8, 5, 5.2, where I would be happy to just monitor this patient and not do anything. So
Right.
what TSH elevation he's talking about, I'm not clear.
Yeah.
But if it is 7 or above, yeah, certainly, except if it's an elderly patient, I would still not be bothered with a TSH of 7 or 10 also, if it is say 70 plus.
Right. And if the free T4 is also high, then of course we need to keep in mind the conditions that Dr. Sahai has mentioned of TSH secreting adenoma or thyroid hormone resistance. Right. And the final question to Dr. Lamba, how to interpret TSH level in someone who is receiving high dose of steroid? Does it have a suppressive effect on TSH?
The high doses of steroid do tend to suppress the TSH levels and also to some extent conversion of T4 to T3. And that is why what we term as a sick euthyroid syndrome, many of our cases in the ICU will have these abnormal reports where you find that the levels of T3, T4, TSH are variable because of this influence of various drugs we give to them. So I think so that too much emphasis should not be, you may not need to start therapy in this case with slightly abnormal levels when the patient is on very high dose of steroid. And the patient will be reevaluated when the steroid dose is either reduced or stopped.
Right, excellent. So I think we had a very good discussion all around thyrotoxicosis. I would just, before I hand over back to Intas, like to mention that when we are treating patients of hyperthyroidism, maybe with medical treatment, initially the test that I advise would be maybe a T3 and a free T4, not a TSH, because the TSH tends to remain suppressed for quite a long time. And unnecessarily, patients become bothered. The TSH is less than 0.005. And so patients say, what's happening? My TSH is still suppressed. So in order not to bring that into our view, into the patient's view, I actually ask them to do just a T3 and free T4. And if they are within the normal limit, I'm quite happy. There'll be so many instances where T3, T4 are normal, but TSH remains suppressed, and it can remain suppressed for months together. That's something we need to remember, and that on its own does not need increase in dose of antithyroid medications. So with these few words, I would profusely thank our panelists this evening who made a difficult job so easy. So specifically, I'd like to mention Dr. Rakesh Sahai, Dr. P.S. Lamba, Dr. Srirang Godbole, Dr. Ritesh Agarwala. A big hand to all of you, and of course to our delegates all over who have stimulated with very interesting, insightful questions, which we may or may not have been able to answer to your satisfaction, but we tried our best. And so now it's back to the INTAS team, Mr. Jinay Kuruvilla.
Doctor, thanks for handing back to me. We could discuss about a interesting disease area today, and I'm sure all the attending doctors would have gone through different facets of managing the patients of thyrotoxicosis. What would be more interesting is the complex cases being discussed by the panelists today, and I'm sure a lot of these finer nuances can be applied in clinical practice by each of the attending doctors. I would like to individually thank Dr. Rakesh Sahai, Dr. Srirang Godbole, Dr. P.S. Lamba, and Dr. Ritesh Agrawala for sharing their insights during this program and for their valuable addition for discussing on this topic as well. We are greatly indebted to Dr. Shubhankar Chaudhary for always curating very insightful topics for the attendees, and it's the verdict of it is always all the programs have hit more than 1,500 doctors so far, and today again we have seen 1,548 doctors are in attendance. Dr. Shubhankar Chaudhary has always brought in the challenging topics, and the some great questions to be asked to our panelists, keeping them challenged on thinking about how to deal with these patients in different situations. Thankful to Doctor for the same. Thanks to all our attendees who have been a part of this program, and thanks for supporting us throughout this journey of 21 episodes. And I'm sure all of you have been greatly valued for being part of one more episode of Endocrine Talk Show. Wishing you all a great night today. Thank you, doctors. Thanks to all the panelists. Good night.
Thank you.
Good night, sir.
Good night, sir.
Thank you.